In this overview, we discuss non-pharmacological treatment of chronic obstructive pulmonary disease, focusing on interventions that improve survival, symptoms, and quality of life. General management begins with smoking cessation, physical activity promotion, vaccination, and structured pulmonary rehabilitation. Therapy should be individualized based on GOLD group classification and patient-specific treatable traits such as symptoms and exacerbation risk. Pulmonary rehabilitation is a comprehensive intervention combining exercise training, education, and behavior change strategies. Exercise training includes endurance, interval, and resistance training to improve functional capacity and reduce dyspnea. Pulmonary rehabilitation programs also include education and self-management training to improve long-term adherence. Baseline assessment in pulmonary rehabilitation includes clinical history, physical examination, spirometry, and health behavior evaluation. Exercise capacity is measured using 6-minute walk distance and shuttle walking tests, along with muscle strength evaluation. Pulmonary rehabilitation typically lasts 6 to 8 weeks, with supervised sessions at least twice per week. Pulmonary rehabilitation improves both physical performance and psychological well-being, and enhances long-term exercise adherence. Long-term oxygen therapy is indicated in patients with arterial oxygen pressure less than or equal to 55 millimeters of mercury, or oxygen saturation less than or equal to 88%. It is also indicated in patients with PaO2 between 55 and 60 millimeters of mercury when cor pulmonale, edema, or polycythemia is present. Long-term oxygen therapy improves survival in severe resting hypoxemia, but does not benefit patients with only moderate desaturation. Oxygen requirements should be reassessed after 60 to 90 days to determine ongoing need. Ambulatory oxygen may improve exercise tolerance in some patients, but does not provide sustained benefit in daily life for non-hypoxemic individuals. Non-invasive ventilation is beneficial in select patients with chronic hypercapnia after exacerbations and can reduce mortality and hospitalizations. Continuous positive airway pressure is indicated in patients with overlap syndrome, combining COPD and obstructive sleep apnea. High-flow nasal therapy may reduce exacerbations, although its effect on mortality remains uncertain. Smoking cessation remains the most important intervention to reduce long-term mortality in chronic obstructive pulmonary disease. Pulmonary rehabilitation reduces mortality after hospitalization and improves functional recovery in advanced disease. Long-term oxygen therapy and long-term non-invasive ventilation both contribute to improved survival in appropriately selected patients. Lung volume reduction surgery improves survival in selected patients with upper lobe emphysema and low exercise capacity. Lung transplantation remains an option for end-stage disease in carefully selected patients. Inhaled triple therapy with LABA, AMA, and inhaled corticosteroids reduces mortality in symptomatic patients with frequent exacerbations. Supportive care focuses on relieving dyspnea, fatigue, anxiety, and insomnia through a multimodal approach. Non-pharmacological dyspnea relief includes breathing techniques, fan therapy, neuromuscular stimulation, and pulmonary rehabilitation. Nutritional support improves muscle strength, exercise capacity, and overall quality of life in advanced chronic obstructive pulmonary disease. Psychological interventions such as cognitive behavioral therapy, mindfulness, yoga, and relaxation techniques reduce anxiety and depression. Early advanced care planning and palliative care integration are essential in advanced disease to improve end-of-life quality and align treatment goals. Non-pharmacological treatment in chronic obstructive pulmonary disease is foundational, improving survival, function, and quality of life when implemented early and consistently.